Hi, everyone, and welcome to this session on data science for cohorts. So this is a panel session where we have myself, Nikki Mulder, who is going to be the moderator, and then we have two panelists. So just to introduce the session, we're going to discuss in the session the use of data science for discovery in cohorts with a particular focus on challenges, best practices, and lesson learned. And because of the theme of this day, we're going to talk quite a bit about the situation in LMICs. We're hoping to discuss a bit about capacity building efforts. And so I'll give a little bit about background about what we're doing in Africa. Then we'll have experiences from the Global Health Network and then the Inspire Network. And then we hope to have really good interaction and questions from the audience. So please save up your questions. So if you think about the data components of cohorts, you have your clinical data, demographic data, experimental, environmental, and these sort of sit within the research data space. And then from the healthcare, you have additional data in terms of health records. Image data may or may not be, in the research versus the healthcare. And then each of these data sets is, associated with a set of metadata. So we need to think about study design, consent, data management, analysis, data submission, training on each of these. But really, when it comes to the data science, you have to think about the data linkages, data integration, and then how we can apply data science methodologies for novel discoveries. But there are many challenges with respect to data in LMICs. There's scarcity of data, number one, from low resource settings because of the cost of generating data. Infrastructural challenges include access to clinical and research infrastructure, access to data infrastructure in terms of storage and compute, the costs for these, internet limitations, and then the biggie is obviously the skills challenges, data management, analysis and interpretation, and data science skills. So one of the initiatives that we've started recently, we've become involved in, is the NIH Harnessing Data Science for Health Discovery and Innovation in Africa. And this includes a number of different grants, including training, LC, research hubs, and then an open data science platform. So these are developing projects with very diverse disease focus areas, from antimicrobial resistance to SARS to maternal and child health, and very diverse data types from electronic medical records, phenotypes, images, and climate data. And so we're building the open data science platform, which is basically hoping to be a flexible, scalable platform that's really feasible for the African continent. So it has a number of different components. I'm not going to go into any detail because I want to give the panelists some more time to speak. But it's really about bringing together data sets that may be federated or centralized, having access to those data sets, be able to find them and access them, pull them in, grab some data science tools that you need, and then run them on the computing environment of choice, all via easy to use interfaces like workspaces. But the idea here is that we need to be able to make this flexible for African scientists who maybe don't have access to the cloud and access to skills. So, some of the questions we want to answer, in terms of the challenges of cost and internet is, can we provide multiple solutions, including on-premise solutions? And we can use GA4GH standards and APIs to do this. There are challenges with data sharing. So can we address these by ensuring that the data are as open as possible, as closed as necessary, and responsible use and sharing of the data before you do the data science? And then challenges with data science skills. How do we develop the data science competencies and skills and roll these out across African institutions? So these are some of the challenges we're trying to deal with in making open data and data science for cohorts feasible on the continent. Additional challenges obviously are developing data models, working with very diverse data types, harmonization, data linkages, etc. So I'll hand over now to our panelists. So our first panelist is Trudy Lang from the Global Health Network. Let me just stop sharing my screen so I can introduce her. So Trudy is a professor of global health research, the head of Global Health Network, and a senior research scientist in tropical medicine in Nuffield Department of Medicine. She has many, many years of experience in running clinical trials, including trials in the developing world for the pharmaceutical industry, the WHO, and in academia. And she's going to talk a bit about the experiences from the Global Health Network, which is a major international collaborative enterprise that tries to think about how we improve health by improving the research infrastructure. So Trudy, over to you.
Thank you very much. I'm really delighted to be on this panel and try and see where we can contribute to this amazing work that's going on. So I'm just going to briefly talk about what we're trying to do within the Global Health Network, but hopefully leave much more to the panel discussion. So it's a well-known fact that far too much of the world's research happens in the global north and very little benefit to the global south. And then worse than that, even much of the research that does happen, much of the capacity building and skills that are left don't necessarily benefit the right people. I think data science and all its advances that are happening, it should be something that's really focused on in trying to address this inequity, because the way that research is moving is changing very quickly. We've seen that with COVID. Many of us who worked on the disease outbreaks like Zika and Ebola saw it, but it's also happening in things like cancer and oncology's whole advances are being made are just tremendous, but also things like Alzheimer's and heart disease. In the global south, there are huge challenges to health, and some of the ways that was just captured in that beautiful slide that Nikki's showed us with the systems of data capture in cohorts just show the opportunities that are there for leapfrogging with some of this and putting data science as a focus for maybe helping shift that balance of where the inequities are, but also making sure that people in low resource settings just are not left behind with all these progresses that are going on. So just to put this in context, when we talk about health research, there's obviously and often a lot of focus on clinical trials, but we know that we need every type of data to address any questions. And whilst we often have been talking around this now in the sort of lens of a pandemic, I always like to push people back and just show this is true for every disease and in every setting. We need this whole ecosystem of types of study, and every study has the same component elements that need for it to be generating safe, accurate, and ethical data. And data science is a fundamental component of all of that, as I'm going to say. But I think what's really important to keep in mind is, that data generation in every single type of health research study we undertake. So we have all these different types of studies, but all of them can break down to the same component steps: to set a good question, to measure the right thing in the right setting, in the right context, to plan and operationalize that research, which means training the team, working with the community, making sure it's a really viable study in that context, and making sure then that the findings are taken up into policy and practice. And data science, in terms of managing the data, analyzing it, sharing it, getting it used, making it available for others to use, are just absolutely fundamental. But the good news to this story is the things that make it difficult don't really vary whether you're working on social science, clinical trial, observational or surveillance studies. And so if we work together to try and work out where there is excellence and how we can share that, we can all make progress much, much faster. So the Global Health Network has been running for about 12 years, and it's grown to be this really massive ecosystem, really, of research organisations that come and use the platform to share their outputs, but also hundreds of thousands of frontline researchers, healthcare workers, lab staff, data managers, pharmacists who come every day to find tools and resources. And so we have a focus on trying to provide these to researchers in the Global South. And it really is working to mobilise excellence, almost like osmosis, from groups that don't have experience, from those who have really strong skills and resources that they can share with other groups. And so it is a knowledge platform. It's got fantastic digital technology behind it, which we've spent years developing. But I always say that the digital platform is just the vehicle. What the Global Health Network really is now are the hundreds of thousands of people that come to it every day to access tools and resources, but also the many, many research organisations and networks that use the platform to share their outputs and engage more widely. So there is this vast digital hub, and we've had millions of online training courses taken. We can issue DOI numbers so people can share their SOPs or their data management systems or whatever they want. And it creates this nice community of practice flow of information. But we also operate very much on the ground in the regions and have a whole, I think we've got over 50 research coordinators now who act as these knowledge mobilization facilitators across the franchise system that we have across Africa, Asia and Latin America. We've also recently made a WHO collaborating centre, and that's because we share the ethos of the science division in WHO to try and enable health research in every healthcare setting. And so whilst there's this digital platform behind the scenes, a lot of what we do is in the regions, running maybe data science clinics in hospitals, or running a workshop in a city on engagement with research or how to improve regulations. So it completely varies on the need locally, but it's this nice blend of face-to-face activities with the backup of the online resources that are there. Just to hone down briefly on data science, we do have a whole community of practice that's dedicated just for sharing expertise in data science across the global south, so linking up initiatives across Africa, Asia and Latin America. I love how this diagram we've got just matches entirely with what Nikki just presented in these component pieces that are so crucial to ensuring good data science. And we really like to collaborate with groups to share their brilliant outputs on this and help us connect that South-South sharing as well. So it'd be really great to keep talking after this panel and see how we can share some of those brilliant outputs that are available now. So just to say that this is a lot of work from a lot of connected organisations, and I'm really keen to try and collaborate as widely as we can. So thanks again for asking me today, and keen to jump into the panel discussions.
Thanks, Judy. Such an amazing network, and you know, to have this collection of data scientists together and have this critical mass, I think, is essential. So I will now introduce the second panelist. So Jim Titus from the Inspire Network. He's a professor of applied biostatistics at the London School of Hygiene and Tropical Medicine and a co-founder of the Inspire Network. He's worked with several health and demographics surveillance systems over the last 32 years, initially working with In-Depth, who you heard about in previous talks today. He's focused on training African biostatisticians and developing opportunities for them to expand their work. So Jim, over to you.
Thank you. Just had to unmute myself. Yes. Thank you very much. And thank you for your introduction. And thank you, Trudy, for explaining, giving a good overview on that. I only have one slide, which basically goes through the hierarchy of needs for data science. And I think this, I wanted to sort of go through this in a couple of ways to say that, I think there's a lot that we're doing, which is very technical in nature about how we do various aspects of this data science and build up the pipeline. But I think that what we really need to do is to make sure that we have the right standards by which we can use this. And by that, I mean, let's make sure that the data that we produce are going to be fair, they're going to be sustainable, and they're going to be ethical. And I think just to go back over that from, let's say, 30 years ago, when the In-Depth network was starting off on the idea of how do we actually compare results from different population cohorts across Africa, well, across many countries of the world, but the parts I know are in Africa. And they were sort of like wanting to concentrate on this collect bit down here, the way that we collect our data in a consistent way in order to be able to answer questions about fertility, to answer questions about mortality, to be able to look at cause specific mortality in that. And the emphasis back then was on the collecting of the data and to make sure that we're collecting consistent data. And as we moved forward and we said, well, we can link our population data with disease-specific data. And I'm thinking here of the Alpha network, where we link that with HIV data, and then with NCD data, and with other disease data such as TB and malaria. And of course, we're moving up this hierarchy of needs, and we're working out how we can actually link those data into a common data model. And now we've got up to the stage where we have got common data models which can link not just one or two databases, not just data from two different sources, but as Nikki showed with her slide, from lots of different sources. so that we can compare the population experience with the clinic experience, with the genetic data, with the environmental data, and all of those can be put in as exposures for our outcomes that we're looking at there. But the key question here is to make sure that we are having fair data. And just because we have a common data model doesn't mean to say it is going to be fair. And by fair, I mean, is it findable by others? Is it accessible by others? Is it interoperable? And is it reusable? And to bigger teams, maybe to the people in IHCC, that might be possible. But with the smaller teams, there's a lot of work that needs to be done to make sure that data are available to them so that they can use that to undertake more advanced analysis with their own data. I just want to say something about sustainable as well, in that many of the smaller HDSS are very worried about their own data. They need their data in order to be able to continue the funding that they have. And they're worried about contributing data to other to larger operations who might use this data and take it away. And we've got to make sure that the data that they use is sustainable, and that the OMOP data that they have is available to them so that they can be added to publications. They can be recognized and they can be acknowledged for the contributions that they make. And so just because we're contributing our data to a common data model, we need to make sure that we acknowledge everybody that is contributing that data to the common data model. And finally, I suppose ethics is the underlying component to this, because ethics does determine what we do with the data, how we manage the confidentiality and the of the data and the rights and the of the participants to that. But underlying all of that is, what is this data for? These data are not there for their own sakes. These data are there to enable us to improve the health of people living in Africa and in other low and middle income countries. And I think those qualities and those need to be displayed at every single level of this hierarchy. It's not just a technical aspect. It is one about the standards and the justice that we're using within that. Okay, I shall stop there and let us get some questions. Thank you.
Thank you very much. And yeah, the importance of fair is just cannot be overstated. So invite the audience to please submit your questions. In the meantime, I'm going to get started with some of the questions of my own. So I'll start with Jim. I know the Inspire Network is still reasonably young, but have you seen any applications so far of data science where you get to that endpoint, you know, of a health intervention? Or can you see, if it hasn't happened yet, can you see where that might happen? Some examples, perhaps?
Sorry, was that a question to me? I missed some of the question. Yes, sorry.
So yeah, so it was, I'm asking, have you seen an example yet in Inspire where you've used data science to actually get to a health intervention? Or if not, can you see, perhaps if I provide an example of where you see this might be the potential?
I think the potential there is by looking at getting the data from the different sources and being able to compare that and seeing where an intervention worked in one place. And we're looking at this with some mental health data to see where an intervention worked well in one place, but it didn't work quite so well in another place. And having that comparison enables us to then look at more closely at the details within it to see why is it's working in one place and not in another place. And I think that is the potential there of combining data and comparing the same intervention in different places to enable us to see why it works in one place and not in another place.
Thank you. So Trudy, I was interested in these communities of practice for data science. So can you maybe talk to us a bit about how they can help to build the skills? So we know that data science is so multidisciplinary. So you either need to have lots of skills yourself or work with different communities, different collaborations where each person has their own set of skills and you bring those together. So how can the community of practice in data science help to sort of build those skill sets, and particularly in LMICs?
Yeah, thank you. I think, gosh, if there's anywhere where this philosophy of community of practice can be applied, it's this. And I think what's been really nice from all three of our presentation is it doesn't matter, does it, if you're working on HIV, Zika, oncology, all those same building blocks, the same components are exactly the same. And for all of us who've moved between working for different disease areas, we know this to be true. And I think there's a lot of sort of myths and misperceptions in data science, that it's difficult and complicated and we can't do it and we haven't got the skills and abilities. But of course they can be put in place and they can be taught. And there is so much expertise and knowledge out there, especially and in the global south, working in very similar contexts, even if it's on different diseases. And so I think the opportunity to share excellence between groups working in Peru and the Gambia, or Nepal and Sri Lanka, are huge, and we just need to do more of it. And we've shown this in other areas, and we've done, you know, Jim and I have known each other probably more than 20 years, and we've been trying to do this for decades. But I think what's happened in this time is this recognition that, you know, as academics, we're not brought up to share. We compete for funding and publications, but actually if we share our methodology and how we do it, we all progress faster. But there hasn't been very much a focus on sharing the how to. And a community of practice is defined by a group of practitioners who share the same challenge, working together to all get there faster. And so we know this works, and we've with the Global Health Network running for all these years, we've seen just really fantastic examples of groups helping each other and sharing excellence. And so I think some of those big chunky areas where they perceived as being really difficult, but they're ubiquitous, you know, getting permissions to use data, building trust, putting community engagement processes in place so people understand why you're collecting that data, getting the you know, standards right, knowing what's there in terms of metadata dictionaries, all of those pieces. I don't think we need to do anything new in data science. I think there's just so much excellence out there in the global south. But if we can create that mechanism for that excellence to flow from between organisation and between teams and individuals, I think that will be remarkable. So I hope what we're able to do with the expertise we've gained in this is give that neutral, open, trusted space where that can happen, where it's non-competitive. You know, the Global Health Network is a community. It's not doing any actual research itself. It's this very sort of trusted, open area to do that. And so I'm really excited about how that might play out. So it's just applying that same community practice that is used everywhere on the internet and just putting it here, but also face to face. We can do that in data science clinics and hospitals and that sort of thing too.
Yeah, absolutely. I think also bringing it, as you said, bringing it into the hospitals and the clinics. People always think of data science as sitting, you know, with the techie people, and you know, it doesn't apply to them, but really that's the end point. So we have a kind of a question comment from Jeff Ginsberg. So it's related to my question on skills. It seems to me that DSI Africa, Inspire and Global Health Network and IHCC can support a global mentorship and training platform to help young investigators become leaders in the field. So I don't know if you want to respond to that, Trudy, and then Jim.
Yeah, absolutely. And I think this is a really crucial part of this community of practice idea. So across the Global Health Network, it's we've got many resources to try and build lasting, capable teams. And so that diagram I showed about all the different component areas of health research, the whole team need all those different skill sets. Another important part of that is even simple things like research management, you know, managing grants, contracts, all those pieces, but also having a career track record system. And so we work with WHO TDR, and we have a professional development scheme for researchers, which measures research competencies across all of those areas and tracks it over time. And to be part of that scheme, you have to have a mentor. And if you don't have a mentor, we'll help find one. And so that's a really nice TDR-led facility to track research competencies and build those lasting, capable teams. So if anybody wants to find out more about that, then, you know, really delighted to tell you more about those as well.
Thank you. Jim, are there any mentorship opportunities in Inspire?
So I think this is another aspect that I think Inspire and first of all is scaling up the training and making sure that the scaling is not just for IT people, but it's for everybody who wants to get involved in it, whether it's data managers, whether it's lab people, whether it's clinical people, whatever, so that they can understand what their data are capable of and how they can use those data in the best possible way. Mentorship is one of these things, as mentioned, and I think tying that in with the building of skills so that people build skills and then get mentored to use those skills, because learning skills is one thing, but using the skills is something much, much more valuable. And I think mentoring people to use the skills that they learn in courses, so that they can, and getting those courses into the places where they're needed, so that is good. I think the structures are there, and I think, as Trudy says, everything is in place. The structures, even things like developing, there are a lot of things that do need to be developed to properly understand African healthcare and health concepts within the population. And some of those are not there at the moment, but the structures are there to enable us to put what we know into that particular data science application, so that we can build the metadata, we can build the vocabularies, we can then use that to explain what is it that we're seeing here that is different from what we're seeing in other places. So I think that training, mentorship, and utilizing the structures is part of what we should be doing here.
Absolutely, thank you. So we have a question from Carolyn Williams. I am struck recently by the need to engage with community and thinking widely about community, which includes government, public, patients, care providers, to ensure that we have the laws and the social norms in place for advances. Can you share more how you have engaged community, including the policymakers and the data creators, and including clinical staff? So Jim, do you want to start?
Sure, and I think important there that community has all of these diverse thoughts on it, and I think the government is an important player in there, because the government actually has got lots of data, have created the right data structures for the data that they are collecting and using, and I think to enable them to feel, I mean, we have said elsewhere, data moves or flows at the speed of trust. And I think if the governments and the policymakers trust the use of the data and can see how they can use the data themselves, then I think that is very much a matter that will help bring the data together, so that we can all analyze it together. So community is not just the IT community, not just the medical community, but it is also NGOs and its other stakeholders, but also the government as well. And all of those need to be involved. Without them, it won't be nearly as effective.
Thank you. Trudy, did you have any response to that?
Yeah, I think there's two elements I'd like to bring in. One is that cycle I showed about the research ecosystem and how it needs to begin, continue, and end with the community. And Jim's right, who are we talking about for the community? It's the staff in the healthcare setting where you're running the study. It's obviously the beneficiaries of the research, and then it's the everybody you're going to be working with throughout the process. Sorry. And the every point on that chain, from setting the question to operationalizing the study, and importantly taking the findings back into policy, it should be planned within your protocol how you're going to do that. So my other point is then on support and tools to make sure you're doing that really well. And there's an area called MESH, which is within the Global Health Network, that is a Wellcome Trust supported resource centre, which has been running for years and has some fantastic resources with from different disease areas and different regions around how to do that. So there's lots of existing know-how on this already, but I do think we need to get better at it for data science, as Jim said. And my earlier point about leapfrogging and this opportunity we have to use advances in using real-world data and doing some really clever analysis within data sets collected by governments is vast, and we've got to bring the community with us to do that.
Thank you. So I don't see any more questions from the audience. So we have this issue of Jim talked about the trust and, the community engagement. So sometimes the original ethics maybe hadn't sort of specified, the end use, like, data science, because, maybe this wasn't around when the original ethics was, introduced, when the consents were taken. So how do we make sure that in doing, in running all these really high-tech data science analyses, that we still respect the original consents of the participants? Jim, do you have some insights from the Inspire network on that?
So what we're trying to do in Inspire is to say that there's going to be different levels of protection, so that we do have, the original data will still be there with the study owners, with the people who collected it and who have those data. But in order to share that with other people within the Inspire network or within a larger network, they will have to perturb the data. They'll have to make it slightly de-identify it so that it can be anonymized, so that people are not going to be identified. But that data will still be real-world data. That data will still be available for analysis, and it will give us the answers which we can use with the policymakers. Now, if we want to share it further with the whole world, then we're going to have to do something else. And this is where something like synthetic data, and we're sort of like saying that if you want to share this with the whole world, perhaps the best way to do that is to make some synthetic data which has the same characteristics as the original population, but doesn't actually have any real people in it. And that would be available then for people to demonstrate, to use, to train, to develop their own analysis programs. Yeah.
Thank you. And unfortunately, our time is up. Time goes so quickly, and I was really enjoying the discussion. So I want to thank our panelists very much. We have to stick to time, unfortunately, because the next session will be starting. So thank you very much for your insights, and I hope people will continue to ask questions on the forum. And yeah, we look forward to further engagements about data science for cohorts. Thank you.